Thank you for this opportunity to speak today at the AWTTC Lunch and Learn, which today we're looking at management of menopause, prescribing HRT, and specifically thinking about the prescribing intervals. My name's Helen Munro and I'm a consultant in sexual and reproductive healthcare in Hywel Dda and a menopause specialist. I just want to flag that I've had honorariums in the past from Theramex to present at some of their conferences. So what we'll be covering off today, so I'll be just touching upon menopause a bit more generally, thinking about the impact of the menopause, thinking about those prescribing intervals and the annual review, looking at the supporting pathways that we have in Wales, the community health pathways, and then the work around women's health hubs and the women's health plan. So the menopause, as many of you know, is a retrospective diagnosis. Women usually have gone through the menopause around about the age of 51 and 52, but we can only really diagnose it once they've had at least 12 months of no periods. And for women, this can often be quite exasperating for them, waiting for that final period to happen, and they've often going through many years of hormonal fluctuations which can bring on symptoms attributable to the menopause which impact in terms of their quality of life. And we know that although 51 is the average age of menopause in the UK, women from different ethnic backgrounds can experience the menopause younger, and certainly women who have had treatment for cancers, for example, can be put into a menopause much sooner, or those who've gone through surgery. So it's important that we take each woman as they come into our clinic on an individual basis and find out what their experiences are and how it is impacting on their life. There are 220,000 women currently in Wales aged between the ages of 45 and 55, so a significant number of women who are at different stages of the perimenopause and menopause. And of course, it's important to think about how that is impacting on them, their relationships, and of course their work life as well. I just wanted to highlight the SWAN study, which is a really interesting longitudinal study to look at if you haven't looked at it before. It started in 1994 in America and has so far collected data around 3,000 women and followed them up, again from different ethnicities, looking and thinking about how the menopause affects women in different ways. So really interesting study to think about women from different backgrounds and how menopause can impact them, and also lifestyle habits such as smoking, for example, which can actually bring on an earlier age of natural menopause. And of course, the menopause affects 51% of the population, and we have been inundated, I think, over the last 5 years or so with different experiences from celebrities, from personalities who have been very open about their experience of the menopause. In many ways, this has been a positive thing. It's reduced that stigma and embarrassment around talking about this important stage of women's lives. But of course, the majority of women may not feel comfortable about talking about it and often suffer in silence. And so that's why it's so important that we create spaces and places and have clinics where we have staff who are educated and skilled to be able to support women going through the menopause, and ensure that we can give open access to all who need it. And of course, in thinking about the symptoms that we know are attributable to the menopause, they are multiple, and there's 34 that are often listed. But many women can have slightly different symptoms or present in different ways, and it's important that we listen to them and don't disregard what they present with. 80 to 90% of women will experience menopausal symptoms, and although on average they're lasting round about 4 years, for a number of women they can go on a lot longer. So if we have women that are presenting in their late 50s or 60s, again, it's important that we don't disregard what they're saying to us, because they could still be experiencing symptoms despite the fact that their periods stopped more than a decade ago. And for a quarter of these women, they will be having debilitating symptoms, so where their symptoms are having considerable impact in terms of quality of life and their ability to function day to day. And we know that from published evidence, this is having a huge impact in terms of the economy of the country. There is some suggestion that £1.5 billion per annum are lost in terms of that ripple effect of women who are having to either reduce hours at work or give up work because of their menopausal symptoms. Women often will reduce their hours or reduce the responsibilities that they have within their workplace, or having to drop roles that they really love and have spent a long time creating a career for because of the impact of the menopause. And unfortunately, many women still feel that their symptoms are not taken seriously and that the menopause is often seen as a joke. So when we think about HRT prescribing, obviously this media coverage and the stories that we hear from celebrities and personalities has had a huge impact in terms of raising awareness and women coming forward and asking for help and support with their menopause, which has been fantastic. And of course, the upshot is that we see that prescribing practices have increased, with a 22% increase in terms of prescribing of HRT over 22 and 23, with more than 13 million HRT items being prescribed. We've had a change in the way we prescribe, thinking about first-line treatments using more body-identical progesterone, eutrogeston, for example, and also thinking about those transdermal estrogens as first-line. But data from England has shown that the way that we're prescribing, unfortunately, does not seem to be having equal effect across all people. And in fact, those from more deprived areas do not seem to be accessing HRT in the same way. And this was reflected equally here in Wales, and Andrew Evans, our Chief Pharmacy Officer, and Richard Baldero published this paper last year, which reflected similarly here in Wales that women from more deprived areas do not seem to be having equal access to HRT here in Wales. And so it's really important that we think about the communities in which we work, the people who we're seeing coming through, and those, and perhaps more proactively offering HRT to women that we think may benefit from it, who might not put themselves forward immediately. And of course, when we do start prescribing HRT, the intervals in which we prescribe seem to be quite different across Wales. Sometimes it's prescribing at 28-day intervals, sometimes it's 3 months, sometimes it's 6 months, sometimes it's longer. But what I do hear often is that the very short prescribing intervals of 28 days seems to be negatively impacting patients. And in these 3 coloured boxes, there are 3 quotes that I've just picked up from patients over the last few weeks of clinics who have had negative experience of short prescribing intervals. One lady said that she felt like she lived at the pharmacist. Another asked me to write to the GP for a longer prescription because she kept running out, which was obviously impacting in terms of her symptom control. And a third one, unfortunately, who was in a really upset way, in tears, said that she was considering giving up HRT altogether because she just could not find the time in her busy life schedule as a carer to be able to constantly keep going to the GP asking for a repeat prescription and then having to attend the pharmacist. And of course, accessing GPs can be a little bit more challenging. Not everybody uses the NHS app for repeat prescriptions. Sometimes it's having to either physically attend or make phone calls. And this, of course, is an extra burden for women in terms of being able to support their menopause journey. So I was having a look at where this 28-day prescribing recommendation came from, and I found the 2010-2011 annual operating framework, which seemed to imply that a 28 prescribing interval was supported because it would reduce waste and improve adherence. But actually, further publications after this didn't seem to show any evidence for this. And in fact, the All Wales Review for prescribing intervals in 2013 felt that there was no robust evidence to suggest that it would either reduce waste or improve adherence. And in fact, there was a potential further negative impact on pharmacists for excessive workload of these shorter prescriptions. And so what did that publication find around 28-day intervals for evidence and intended consequences. So in fact, it showed that probably a 90-day interval was better at supporting adherence, that there was potential costs associated with the shorter prescribing intervals, and that of course there was this impact on our carbon footprint if patients were having to attend monthly for either the GPs or the pharmacists to order and collect their prescriptions. The review looked at benefits and disbenefits of prescribing longer than the 28 days, and it felt that for certainly benefits that this would free up pharmacy time to be able to focus on more direct patient contact, that it would improve patient adherence, and that it was overall patient preference to have longer prescribing intervals. Potential disbenefits: there was loss of income to the community pharmacy potentially, a possible risk for the individual patient, and that certainly for the older population there was that reduced opportunity for that patient contact, which may not be as important in the cohort of patients that we're looking at for HRT. So following on from this, the All Wales Guidance for Prescribing Intervals came out with some recommendations, and certainly what is now supported is that where it's clinically appropriate, patients can be moved from 28-day prescribing intervals to longer prescribing intervals, and that should be taken in discussion with the patient, so a shared decision-making process, and that the annual review is a great opportunity to be able to have that discussion and think about what prescribing interval actually suits the patient and for which you can then move to. I think the annual HRT review is a fantastic opportunity for a prevention discussion. And we know that, of course, women who are postmenopausal have increased risk of cardiovascular disease, and also thinking around bone health, osteopenia and osteoporosis. And so our HRT review should include multiple aspects. And I know that here in Wales, often the HRT review is the responsibility of our pharmacists. In NICE 23, we are given some advice that after the patient is established on HRT, so once they are at a dose that suits them and is managing their symptoms, then actually it could be an annual review thereafter for side effects, symptom control, and potentially obviously to review any changes in bleeding. We have an opportunity to think about Q-risk scores, around potentially looking at FRAX scores for bone density, whether a cholesterol check is needed, and of course thinking about height to waist ratio as recommended by the British Heart Foundation. We also have opportunity to talk about screening and whether they're up to date with cervical screening and also breast screening, thinking about any contraception needs, certainly for perimenopausal women, but also thinking about relationships. And I just wanted to flag a paper that was published by AVA and IRSI, organisations that I know many of you will be familiar with, who've obviously picked up on the fact that unfortunately during the perimenopause and menopause, the incidences of domestic abuse and sexual violence do unfortunately increase. And so the annual review is a perfect opportunity where you can do some safeguarding around patients, ensuring that if they do need help and support, that you can signpost them appropriately. And of course, here in Wales, we have community health pathways, which is available through our intranet sites. And these are pathways that support in terms of prescribing of HRT, management of unscheduled bleeding of HRT, and we're in the early discussions of also putting together a pathway for supporting for the annual review and what that annual review could and should look like. There is so much information and evidence, so much information out there for patients now that we have to ensure that it's evidence-based where we're signposting women, particularly around lifestyle and diet, and to support them with with their HRT as well as non-hormonal ways of managing their symptoms. So it's important that you think of 2-3 websites that you can signpost women to as part of that consultation. I often use the Women's Health Concern, which is the patient-facing arm of the British Menopause Society, and there are not only some patient information leaflets, but there are some videos there that are accessible. And I also often point women towards Rock My Menopause as well. So having 2-3 sites that you know are evidence-based that you can refer women to will be really helpful. The Women's Health Plan is almost a year old now, and of course within the Women's Health Plan there is a priority for menopause care, and this was of course reflecting the fact that we knew that access to menopause services were quite varied across Wales, and it was important that we put this at the heart of the Women's Health Plan to ensure that we could raise the standards and improve access across all health boards. And this is now being accompanied by a ministerial priority, which is around women's health hubs. As many of you are aware, and you may be involved with your local stakeholder groups around development and delivery of hubs. It's often they are focusing on menopause care and access to menopause care and being led by primary care in the majority of health boards. So an opportunity for pharmacists, for nurses, advanced nurse practitioners and GPs to be able to deliver menopause care through community settings, which of course will improve access so much. So if you are not aware of the local projects that are going on in your health board, do reach out to me at the end of this and I will be happy to give you the information of your clinical lead who is leading on this project. So my take-home messages for you today are: consider a shared decision-making approach to HRT, particularly thinking about longer durations of HRT prescribing, which may be more supportive for that person. Have that unique tailored approach to them in terms of what their needs are. And if you have an opportunity to get involved with your local health hub, please do. Many thanks for listening, and I'm open now to any questions.